Okay, post-op care. So the post-op period begins from when the last incision is closed, meaning the last staple or the last stitch is applied, then the post-op period begins. The patient immediately goes to the PACU, post-anesthesia care unit. Whether or not the patient is here for inpatient or outpatient surgery, they always go to PACU. Purpose of the PACU is, of course, to monitor how the patient tolerated the procedure and the medications that were given, including anesthesia, the sedative, the pain medication, muscle relaxants, and benzodiazepines that were administered. And in addition, the patient also is monitored for immediate complications after the surgery. Okay, so care begins in the PACU. We won't test on the faces of the PACU because we are not PACU nurses. What we will focus on is what do we assess? Okay, so let's begin here. So the patient will be assessed for, like I mentioned, how they tolerated the surgery, including the medications, and then monitor the patient for potential complications in the immediate post-op period. Now, complications will continue not only on post-op day 0, but also post-op day 1, 2, 3, and so on. Now, we cannot hold the patient for indefinitely. The focus, of course, is to get the patient as quickly out of the hospital as possible, not only for financial reasons, but also for to follow guidelines. Okay, so let's say even for bariatric surgeries, for instance, if you're getting a gastric sleeve, for instance, so that's usually an overnight procedure. So patient comes in today, post-op day 0, they're usually discharged post-op day 1. And of course, the instructions on the discharge given by the nurse will include when to return or when to call the physician. Okay, what symptoms are reportable, which indicate what complications. All right, so we don't have to keep the patient forever. Right, so the patient is discharged as soon as possible. So as soon as stable, but I should say that. Right. So upon receiving the patient, of course, you will look at the patient's vital signs first. Then you look at the incision. What is the condition? Now, what is the rule about the first post-op dressing? So what do we do again? What is the rule about the first surgical dressing?
Thank you.
So who changes the first surgical dressing?
Residents and doctors.
Okay, the surgeons, as a rule, it should be the surgeons, unless otherwise specified. So since this is the first surgical dressing, what is the rule? Do we change it?
No,
So how do we assess the incisions if we cannot remove the surgical dressing?
we check for redness.
Okay, so yeah, that's all you can do. You do not open the incision, okay, because opening it, of course, exposes it to infection, right? So you leave the surgical dressing alone. You assess the condition of the dressing. All you do on your documentation is, of course, can you assess the incision? So what do you put on your documentation? Unable to assess. Okay, but instead you describe the dressing. What is the condition of the dressing? Is it clean? Is it wet? Is it soaking wet? How wet? And what is the drainage that you saw? Okay, so you document, describe the dressing. Okay, we do not remove the surgical dressing. Unless, of course, if the surgical dressing, let's say this is a orthopedic procedure, so most dressings are clear, so you can see the incision through the dressing. But most other dressings are gauze. Okay, they have pressure dressing, so of course you cannot see the incision. All right, are we clear? Right. So you just describe the condition of the dressing, and then you also examine, are there any tubes? So the procedures that will require drainage tubes are biliary procedures, meaning the patient had any gallbladder surgery, for instance, so expected drain. Also for large, we call large abdominal incisions or procedures as exploratory laparotomy. So XLAP, you expect a drain because it's a big incision. So of course there will be bleeding inside. So the doctor will leave a drain. Okay, so the purpose of draining the surgical incision is of course to keep it dry. So the general rule is the wound, a wet wound must be kept dry and a dry wound must be kept moist. Are we clear? Right. So can an incision heal if it's soaking wet? No. So that's why we have a drain, right?
The dry wound must be kept moist.
Moist, yeah. Then you examine the patients after the drains, you examine the blood pressure. Okay. The patient received several CNS depressants, so beginning from the opioids that were given, the general anesthetics, the muscle relaxant or muscle paralyzers, all depress the CNS. So first you monitor the patient's blood pressure, heart rate, and then the patient's ability to to move. Okay, can they get up safely? Right. So you assess the patient's blood pressure. Are there any changes when they change position? Okay, so you monitor the blood pressure.
Like orthostatic, because they could.
Yeah, that's what we are checking the blood pressure for. Right, so the anesthesiologist or the nurse anesthetist will speak with the PACU nurse. The doctor will give the following reports. Okay, I won't read it for you. So it's a long list. Okay, so it'll be a checklist. So on your on Epic, when you fill out the flow sheet, this will be a drop down box, and literally you answer each question. Okay, so beginning from the procedure, for instance, how long was the procedure, drugs that were used, estimated blood loss or EBL, all the way down to patient's language. And then there's usually some, although not all patients, there will be some specific needs or requests. Let's say most frequent requests are the family. So family usually wants to be notified as soon as the patient is out of surgery. Okay, so you see if there are any such special requests, and then please give the courtesy to call the family. Okay, because they're worried sick. Okay, so you don't just go about your care and I say, oh, I'm sorry, I forgot. I didn't think that was part of my job. Well, it is part of your job. Okay, so notify the next of kin. All right. So follow up. Is there any family waiting? Can just tell them that the patient's stable. They'll be able to see the patient soon. Okay. There are no visitors in the PACU. Patients, visitors can see the patient once they're back on the surgical unit. Okay, on the floor. They're not allowed entry into the OR. Okay. Let's go now to specifics. So priority is the airway. Now, especially if the patient was given general anesthesia, so of course they were intubated and put on a mechanical ventilator. And sometimes there are traumatic intubations, so monitor how the patient's airway is. Is there any indication of any swelling, excessive trauma, bleeding that can impair the patient's breathing effort and also the patency of the airway? Oxygen if needed. Maintain the still on airway. Maintain what head of the bed elevation would be best? 30 degrees. We don't really want 45 or 60 because at 45 or higher, the pressure on the coccyx, on the sacral area, is increased. So that will promote pressure injuries. So 30 degrees would be ideal. 30 degrees elevation of the head is enough to both prevent aspiration as well as maintain airway and also prevent excessive pressure on the sacral area. You monitor patient's cardiovascular status beginning from, we're still in the PACU, okay? So the patient's on a cardiac monitor. So we look at the heart rhythm. Are there any changes from the patient's baseline? Because not all patients will have a normal sinus rhythm. Okay, some of them will have arrhythmias that are already present during surgery. So that's why we say, is the patient back to baseline? For hypotension and shock, so we're done with the airway. So we look at the patient's vital signs. Are there any indications of excessive blood loss? Because let's say the anesthesiologist or the surgeon reported a blood loss of approximately 300 ml, which is not significant. However, can the patient continue to bleed after the surgery? Yes, so you watch for signs of those. We just concluded hypovolemic shock, so same assessments. That goes the same for hemorrhage.
So that'll be like, when you're looking for the signs and symptoms of hypovolemic shock, that'll be like hypotension, tachycardia, stuff.
Yeah, same as module 1. Right. So pain relief is paramount. So you administer, if there are no PRN orders given, then what do?
Yes.
You ask for an order. Okay. Anxiety medications, usually either lorazepam, or if the doctor doesn't want something that's strong, they can give Xanax, which is alprazolam, okay, a weaker benzodiazepine, okay, but give the patient something. Please keep in mind what will prevent the patient from moving. We'll go to mobility next. So what will keep the patient from ambulating? Pain. So therefore, how do you promote ambulation? Okay, pain relief. So as soon as you manage the patient's pain, then they will get up. Okay. Okay. So unless otherwise ordered that the patient is on bed rest, because we will rarely see an order for bed rest. So the bed rest patients are only those that have neuro surgeries, meaning brain surgery, and also cardiac, especially for open heart surgery. But for cardiac catheterization, these patients and all other surgeries, they are taken out of bed. Hip, knee surgeries are also taken out of bed on post-op day 0. Okay, they may not be walking yet, but they'll be taken out of bed and put in a chair. All right, so ambulation, mobility is encouraged because we will just have so much post-op complications due to immobility. So if you baby the patient, let's say you say, "Oh, you poor thing, it's okay, you just rest, okay, you're in pain." No, we do not do that. We encourage the patient to ambulate. Okay, so give pain medication, then tell them don't be so meek. Say, "Hey, can we walk, please?" No. Okay, you tell the patient, get up, right? Get up, let's walk. Patient refuses, then you document, report to the physician. Then usually they may not listen to the RN, but when they hear it from the surgeon, then okay, they'll do something. Okay. Post-op nausea vomiting, this is a consequence of not only the surgical procedure, because even if the patient didn't have an abdominal surgery, I mean, this is understandable if the patient had an abdominal procedure. However, if the patient had some joint procedure or any other anatomical site besides the abdominal cavity, the patient will still have post-op nausea vomiting. Now, this is caused by the medications, okay, that we gave. Usually, the anesthetic causes nausea vomiting, and opioids as well. Most of our patients are opioid naive, meaning they're not used to opioids. So one of the complications of opioids are nausea vomiting. And then we we discussed last semester sedation, right? So we've got constipation, which includes which can induce post-op nausea vomiting, pruritus as well. Okay, so we institute aspiration precautions if the patient reports nausea, and then if just like pain, if there are no post-op PRN orders, then ask for an order. Patients may receive multiple antiemetics. We look at the list under cancer, which is in 2 weeks. Because we'll have to control these drugs. You know what? It may be on this table. Okay. Yeah, so we don't have to wait for cancer.
So like, would it be like ondansetron, metoclopramide?
Yeah, we'll look at that list. Okay. So here's your list, table 16-2. So it's a drug chart, so you're responsible for reading your side effects as well as your nursing considerations. Now, which drug you'll use depends on what type of nausea vomiting is your patient having, because there are 3 types of nausea vomiting. First is anticipatory nausea, meaning the patient didn't even receive the drug yet or had the procedure yet, they're already nauseous. There's acute nausea, meaning they're nauseous now. And then finally, we have delayed nausea, meaning they received the drug hours or days ago, but they still feel nauseous now. Okay. So therefore, what type of approaches do we use? Do we prevent nausea?
Prevent, yes.
Can we prevent nausea?
Yes,
Do we treat acute nausea?
yes.
Can we also prevent future nausea? Okay, so the drug you choose, because let's say all of these medications are given. Okay, so we have metoclopramide, chlorperazine, promethazine, dimenhydrinate, hydroxyzine, scopolamine, ondansetron. Look at the action of each drug, okay, so that you know which one to use. Is the patient having acute nausea, or are you trying to prevent nausea? So that you can choose which drug you will be administering, okay? So that you don't just go, oh, I've given this, I'll try this next time. No, use them wisely, okay? So look at the action of metoclopramide. How does it work? Promotes peristalsis. So therefore, what type of vomit nausea will this address? Acute, prevention, or delayed nausea? Promotes peristalsis. So what can this address? Can this address acute nausea? Yes, it can. Can it address prevention of nausea? Yes, also. So it can be both. Chlorperazine. Look at the action.
That's a good.
So this is for acute nausea. Patient's nauseous now, you give it now. Okay. Promethazine. Same thing. This is for acute nausea as well. Now, you may have heard of promethazine when you had some bronchitis, for instance, or the flu. The doctor gave you promethazine, yeah, for cough. Okay, so this can also be used for cough, right? The number one side effect, of course, is this is sedating. Okay, it has sedation as a side effect, so very good for if you have a nasty cough. We sedate you. Are you gonna cough if you're sedated? Dimenhydrinate, so anti-motion sickness, helps with nausea, because when you have motion sickness, are you nauseous as well? Yes. Okay, so this is indicated for preventing nausea. Okay. Then you got hydroxyzine, which can be PO or IV. So this is for acute nausea. Then for scopolamine, same prevention also. Or it can also use for acute nausea. And finally, ondansetron, this is for prevention. Okay. So you're familiar with ondansetron, but now you've learned that is it really for acute nausea? This is best for preventing nausea. Patients nauseous now. Will this be any help? No, this will be better for the next nausea episode. Won't do anything about the current acute nausea. Does that make sense? Okay.
Did you use it for the diagnosis?
Reglan has an indication off-label. It is used for severe migraine. Yes, acute severe migraine. So some drugs have off-label uses. So if you're, if you're questioning a doctor, isn't this for nausea, and then it's given for something else, just look at the drug book. Okay, so research, and then if you can't find anything, then politely ask the doctor. Okay, doctor, I can't find any indication. Why did you order this drug? Okay, so at least you're being polite, you're being respectful. At the same time, you're not making a fool of yourself. Right? Because FYI, doctors also ask the pharmacists for certain medications. I'll give you an example. When we have ESRD patients, ESKD, sorry, no, end-stage kidney disease, people on dialysis, those people have, or even liver disease patients. So they have limited drugs that we can give. Okay, so for that reason, doctors, especially if they're residents, for instance, not really practicing doctors yet, not independent practitioners. So they'll call and consult the pharmacist. Okay, they'll say, okay, I have an ESKD patient. What can I give for this one? Right? So they'll consult. Okay, so it doesn't mean that they're the doctor that they know everything. So same for RNs. Okay, so if you're a new RN, ask questions. Right? And you learn, you learn quicker also. Watch for there are bariatric considerations here. So these patients. So what do you know about bariatric patients? What comorbidities are usually accompanying this diabetes too, right? Hypertension. So you may want to be I'm not saying that's true all the time, but you want to make sure that do they have diabetes? Do they have hypertension? Okay. So when you care for these patients, so you consider those problems, and they may have some sleep apnea problems too, right? Because obese patients may have short necks, correct? So that can cause sleep apnea or other respiratory problems, for instance. So consider that in your care, because the risk for, let's say, DVTs are higher when you have obesity, right? So take extra care for about these patients. Okay. Here they mention high risk for DVTs, obstructive sleep apnea, hypertension, and like I said, diabetes may be a concern as well. I won't test this part because again, we're not PACU nurses. So the PACU nurses follow a certain criteria. The Aldrete score is just one of them. Each hospital will use their own scoring system. So patient meets a certain score, then they are they meet the discharge criteria from PACU. Then the patient can go to the post-op floor. Now, if the patient is never stable after, because we can keep the patient up to 12 hours in the PACU. If the patient continues to be unstable, not meeting criteria for PACU discharge, patient won't stay in the PACU. They'll go to ICU. All right? Because the PACU can only take care of so many patients. Okay? Because now there's a next case coming out. No, don't tell me this one PACU nurse will take care of 6 patients. Okay? So the most they can take care of is 2 or maybe 3 is a stretch. So they have to empty the PACU. So if the patient continues to be unstable, then they'll give report. Then they'll get an order to transfer the patient to the ICU. Okay? Because obviously they did not meet discharge criteria. Patient remains hemodynamically unstable. So they need
You have a connect.
higher level of care.
You
Sorry?
have a connect for PACU.
I'm sorry?
You have a connect for PACU.
ICU and PACU are always hiring. Okay, so don't be shy to apply. Okay, and they're not always asking for experienced nurses. Most hospitals I know even prefer fresh graduates because it's better to train someone from scratch because um, most seasoned nurses, have an attitude already, and then they've already have habits that are hard to
So, yeah.
get rid of, and then they have this attitude that yeah, I know what you mean. What do you mean? Yeah. Look at your, you got your habits that, they don't clean valves, they leave syringes, uncovered. So it's for me, if I'm the manager, give me a fresh graduate. Okay, so I'll tell HR, I want a fresh graduate. And do you want a BSN? I don't care. Give me whatever you got. Okay, and then after they interview you, because it's really the attitude. Okay, so if I'm the hiring manager, I talk to you. If I like, your attitude, I like some, quality like this, and then, you know, pretending like you're, oh, and I have this, you have an attitude. You go somewhere else. Okay. So we want somebody who will work, right? And of course, you want to work with someone you get along with, right? Okay, let's go to, okay, so this is for if the patient, let's say, is on a same day surgery. So this will be your discharge instructions. So what did they have? What medications are they going to take? And you also record, when was the last dose that they got something. Because of course, when they get discharged, you will be prescribing opioids. Although most same-day surgeries now, if indicated, use Tylenol, meaning, let's say, for bariatric surgeries, right? They get Tylenol IV, which is Ofirmiv, every 6 hours, around the clock, whether or not the patient has pain. And then in between, so let's say the Tylenol is given 12-6, 12-6, right? Because that's every 6 hours. So in between, they'll schedule three. They'll give Toradol also. Toradol is what? It's an NSAID, right? Okay, it's an NSAID. So they'll give a non-opioid analgesic as well as an NSAID in between. So technically, if the patient's getting Tylenol IV Q6, then the patient will also be receiving Toradol Q8. Okay, so in between, so around the clock, patient is given. So it will manage the pain, and in between, if the patient has acute bouts of breakthrough pain, then they'll be given a dose of opioids, maybe 2-4 milligrams of morphine. All right. But that's the practice now. So we load you up with round the clock with non-analgesic agents. Again, exception is, of course, if you have open heart surgery, of course, that's a much bigger incision, right? But most laparoscopic surgeries are not given opioids. Okay? Yeah. Other instructions are, of course, dressing. Okay, what do you do with the dressing when they remove the dressings? If there are staples, for instance, then the schedule, usually staples are removed on the 10th day. It's rare that we let it go until 14 days. Okay, so usually staples can be removed depending again on the size of the incision, either on the 7th or the 10th day. Okay, make sure there's a follow-up. Okay, for every patient that has staples, please schedule when to remove them. All right, because otherwise skin will grow over the staples. Then you never know where are the staples. I don't know. Then look, I don't see any staples. The skin has already grown over the staples. Right. So now you have foreign objects in the patient's body, and then next thing you know, they're septic already. What's the source of the sepsis? Here, staples. Okay. Then when to follow up with the surgeon. The surgeon is not only the provider for follow-up. The patient is also expected to see their PCP, okay, their primary care physician, because especially if they have chronic conditions that need managing as well. Because of course the surgery will affect diabetes, won't it not? Will affect COPD or heart disease. Okay. So we go now for inpatient. So if it's a hospitalized patient, no difference from the initial assessment. So we assess the airway, the patient's cardiovascular status. We look at the whether or not they had blood loss, the incision, care of the incision, and then other post-op complications. There are 3 W's which are sources of infection in every post-op patient. First W is wind.
What?
Wind.
Wind?
No, wind
Okay.
from a storm. Next W is water. Next W is wound. Okay. So wind refers to pneumonia that usually happens on the first to the second day. The next W is water, right? So that's UTI, especially if the patient has a Foley. So that's on the second to the third day. So that's why best practice is, when do we discontinue the Foley? As soon as possible, but usually on day 2 or day 3. Okay. So if the patient is post-op day 2 and there's still a Foley, what do you do? Ask, why is this still here? Okay, why is this Foley still here? So ask for, assess your patient, and then ask for an order to discontinue the Foley. Okay, because you're just asking for trouble. Patient will have a UTI, right? So they should be taken out, if not post-op day 0, then at least post-op day 1. Because data says that UTIs form after 48 hours if you have a Foley. Okay, so take it out as soon as possible. Then the last W is the wound. So wound infections usually start around post-op day 3 onwards. It's rare for surgical wounds to get infected on post-op day 0, 1, and 2. Because, I mean, did we not use sterile technique? Yes, so everything was sterile, okay, that we used, unless there was an infection that we didn't know about. But usually, if there's a wound infection during the post-op day 0, 1, and 2, that will be a post-op infection, meaning that will be charged to the hospital, meaning we, as the assumption is, we caused it. Insurance will not pay for that. All right. So, surgical wounds usually get infected, which is now caused, not caused by the surgical procedure, but mishandling of the wound, or we can also attribute that to the patient, that the patient is already out of the hospital. Okay. Because you don't know what people's homes look like. So some people, okay, you have your homes, right? So you think that your patients will have the same home environments. Not really. Some people live with like 13, 15 cats, and they have a surgical wound. They have 3, 5 dogs walking around, they're licking them, and then the incision is in the groin, right? And then the patient's 400 pounds. Okay, so you don't know what the patient's living environments are. Okay, so you should assess that also, although the social worker should, or the case manager should already be assessing these, okay, prior to discharge. Right, let's go to item by item, system by system, sorry. Okay, respiratory first. So preventing respiratory complications, what do we use? How do we prevent respiratory complications, which is pneumonia or lung collapse? Breathing exercises. And how do you promote that? What gadget do we use? Okay, the incentive spirometer. How often do we make sure patient uses them? How many times every hour? Okay, so 10 times every waking hour. Every time the patient's awake, let them do it 10 times. Okay, only 10 times, no more than 10 times. So if it's 10 times every hour, so that means every how many minutes? Every 6 minutes they do it. Okay, never tell the patient to do it consecutively. They have to rest in between. Let's everybody use a incentive spirometer so that we know how the patient feels. So exhale first. Everybody exhale. Okay, don't blow in your in your seatmate. Okay, so just exhale quietly and then put a mouthpiece in front of your mouth, and then inhale slow and deep, like you're yawning. And then exhale normally. How did you feel after that? Better or a little lightheaded? A little lightheaded, right? So imagine if you're doing it more than once every 6 minutes, your patient is going to be on the floor. All right. So how often again? Once every 6 minutes or 10 times every waking hour. Are we clear? All right. So what's the purpose of that? Okay, to prevent pneumonia, prevent atelectasis, because these patients' mobility will be limited for a while. And they can't walk like you and me, so they'll be bedbound or chairbound. So that's not good for secretions, correct? Right. Then coughing and breathing, coughing, deep breathing. Exception for coughing and deep breathing is for neurosurgeries. So the patient had brain trauma, brain surgery, no deep breathing and coughing. Are we clear?
Okay.
There's a do not cough order for those procedures. Otherwise, let's say they have a abdominal incision, so teach them how to splint the incision, how to use a pillow when they cough, right?
So for neuro and what patient? No.
Neuro, brain procedures. Since we cannot absolutely prevent pneumonia, then you should be able to assess or recognize the presence of pneumonia early. So the signs and symptoms are here. Please read them on your own. Hypoxemia is one of the early signs for pneumonia. All right. Best would be if the patient can ambulate. If the patient can ambulate, then this would be even better than an incentives barometer. Okay, ambulation is the best. Okay, so we have here the coughing is contraindicated in patients who have head injuries, etc. And like I said, early ambulation is best. Relieving pain, this would of course be not only for the patient's comfort, but of course to encourage ambulation, early ambulation. Now, pain, unrelieved pain can also affect cardiac function because what dysrhythmia can occur with chronic pain or even with acute pain? Tachycardia, right? Yeah, so tachycardia can result from unrelieved pain. So make sure you do a complete pain assessment and manage it well. If the patient's pain is unrelieved, then discuss it with your provider. Opioid use, don't want to repeat this. We already discussed this thoroughly last term, fourth semester. PCA also we discussed last term. Always use multimodal anesthesia, meaning don't just rely on opioids. They're never good. So make sure there are non-opioids also used in between. I know the non-opioids will not give the immediate high or immediate pain relief as opioids do, but what's the benefit of non-opioids though? Especially for surgical wounds, for surgical pain. Okay, so NSAIDs, not just the addiction really, because this is only a few days. The nature of the pain for surgical pain is really what? Inflammation, correct? Because the patient sustained trauma. Okay, we use scalpels, we move tissues around, so of course there's a lot of inflammation. So would the patient benefit from NSAIDs? Yes. Okay. And at this point, you already know your responsibilities when giving NSAIDs. We finished peptic ulcer disease already. We discussed cardiac effects of NSAIDs last semester also. And also kidneys, right? Kidney complications. For epidurals, because the patient likely will be on anticoagulants, okay, as part of post-op prevention of DVTs. Now, if the patient received an epidural anesthesia, meaning an epidural injection, correct? So those needles are huge. So make sure the patient doesn't receive any anticoagulant within 24 hours. Are we clear? Okay. Because otherwise you'll have a hematoma there. They could bleed into the spinal column. You have hematoma and then that's spinal injury already. Okay. You're familiar with the different types of drains, yeah? You know what a Penrose drain looks like, a JP drain, a Hemovac. These are all fundamentals of nursing. Okay. And this part will be fluid and electrolytes to maintain cardiac output. Make sure a patient also has adequate, this is still part of cardiac output, is kidney function, because they're all related, yeah? Meaning if your patient has enough urine output, which is 30 mLs per hour, or what did we learn again in shock? 0.5 mLs per kilogram per hour. That means, is there adequate perfusion? Yes, that means you have adequate cardiac output. Are we clear? Otherwise, you know, consider maybe patient. So what type of AKI can result after surgery? Pre, intra, or post-renal? Most likely pre, right? Because remember, this patient was NPO, plus the patient had blood loss, right? Okay, so there could be pre-renal AKI. In intrarenal AKI, that is if we use, let's say, a dye, for instance. So let's say this was a cardiac procedure wherein they use an IV dye, then yeah, it could be intra. Or it could also be post-renal in the case of, let's say, if it's a bladder procedure and then there's bleeding in the bladder and now you have clots there which obstructs blood flow, then that would be what will apply. What are our prevention for DVT besides early ambulation? So you got pharmacologic, which are your low molecular weight heparins or unfractionated heparin or the SCDs, right? So you have SCDs, non-pharmacologic as well. When you elevate the legs, where do you pull the pillows? Put the pillows? Where do you put the pillow? Somebody said under the knee. So read, for those who said under the knee, please read the statement. Where do we put the pillow?
Patient should avoid positions that compromise most return, such as raising the bed's knee gauge, placing the pillow under the knees, sitting for long periods, and dangling the legs with pressure at the back of the knees.
Are we clear? So do we do any of these? We avoid these, all right? Yeah. Well, so where do we put the pillow? We can't put it under the knees. We put it
On top?
on the calf. Okay?
Oh.
But avoid the back of the knee because there are blood vessels there.
Oh.
Okay? There are arteries there. Arteries and veins run behind your knee. And as already mentioned, early ambulation will prevent almost all of these. So early ambulation prevents pneumonia, prevents a UTI, prevents a DVT, prevents wound infection because this will help promote drainage, yeah? So the more you ambulate, then the more drainage will come out of the incision and no pressure on injuries as well. So early ambulation. And how again do we promote ambulation? Pain relief, adequate pain relief. If you're not comfortable getting the patient out yourself, let's say patient's quite heavy, then ask the doctor for a physical therapy order, right? So physical therapy will come in, assess the patient. There'll be 2 of them that will come. They'll get the patient out, teach the patient how to ambulate safely. Okay, so it's out of your hands. Also a reminder, because I had a patient in Florida before in home health. The guy had no buttocks. The patient had stage 4 pressure injury. all because he had hip surgery. So what the nurses did was the physical therapist got the patient out of bed at 10 a.m. He sat in the chair. He kept asking, because it was a busy day, he kept asking, can I go back to bed? Of course, nurses will say, what are you talking about? Stay in bed. Next thing you know, it's already 8 p.m.
Oh my.
Okay, so he sat in the chair from 10 a.m. to 8 p.m.
What?
with a hip surgery incision. So a patient, of course, had deep tissue injury as a result, and he paid for it dearly. So I had him for 2 years, but he already had a wound when I got him. That means that wound is over 2 years old already. Because other nurses had him. Then I had him for another 2 years, and the wound is just, I mean, you can see his bone. Okay. He's tall, 6'4". He said he was a NYPD detective. He retired in Florida, and now he's that's him. No but. Okay. And he's had some sepsis, a few bouts of sepsis as well. Okay, so he's been in and out of hospital for septic shock. No, buttocks is not a rectum. Okay, it's a different story.
I know, but I thought the whole thing was going.
So if you're constipated, then your buttocks will be enlarged. Is that what you're saying?
No.
And if you have diarrhea, your buttocks will be gone. Then don't spend for surgeries to enhance your buttocks then. Just stop going to the bathroom. So here are other options to prevent DVTs. Okay. All right, let's go to wound healing now. Specifically, we will examine wound complications. So let's review first, second, and tertiary wound healing intentions again. So what's the meaning of these three? This is how wounds heal. So what type of wounds are surgical incisions? Are they first intention, second, or tertiary intention? Surgical wounds. They are first, okay? Meaning it's not like the doctor carved out muscles and tissue and then put them on the grill, right? It was a nice clean incision, so very minimal tissue loss, correct? Okay, so there should be only primary intention, meaning all the wound needs to do is reapproximate and for the skin to heal. Okay, so as soon as you staple or stitch them, that's it. Second intention wound healings are those that examples are wherein there is considerable tissue loss. Okay, examples are pressure ulcers, for instance, or wounds that are debrided, or burn wounds, for instance. Those are all secondary intention wound healing wounds. Tertiary, on the other hand, is if there's an infection now. So an infected wound has to heal by tertiary intention, meaning we have to heal, we have to treat the infection first before granulation tissue can grow, before skin can approximate. Are we clear? All right. For assessing surgical infections of the wounds, here are your assessments. So always assess for redness, discoloration, warm swelling, unusual tenderness, or drainage. Now, of course, there will be drainage on the first few days of the wound, but typically the drainage stops around the third or fourth day. Any significant drainage on the fifth day and beyond is the wound healing? No. And what's usually the reason why? Why is the surgical wound not healing? It's infected, right? So that infected could be maybe somebody left something there. Maybe there's an instrument there, maybe there's a sponge there, right? Or maybe there's a staple there, right? So we should expect the drainage to decrease every day. Every day, the drainage should steadily decrease. And what is the order of the drainage appearance? So just like in OB, so after labor and delivery, so what is the first drainage that comes out? Yeah. So what is that? Rubra first, right? And then serosa, and then okay. So same thing. So of course the drainage here will start sanguinous, right? Bloody, and then becomes serosanguinous, and then becomes serous, meaning clear or yellow, right?
Repeat that.
Sanguinous, serosanguinous, and then serous. So here are a few factors affecting wound healing: age, location of the wound, patient's comorbidities. Here are drains again. So here are a few complicated wounds. So here are now wounds that heal by secondary or tertiary intention. Have you seen wound vacs? Okay, so here is a wound vac. So who invented this is KCI is the company that first invented it. A lot of China products now came, of course, copyright infringement. They have lesser quality equipment that. So what you're looking at on the figure on the left is a wound. So the black area there is foam. Okay. So how we do it is we try to shape the foam that we apply into the wound bed. This is just clean procedure. Okay, this doesn't have to be sterile. So we have a sponge that we will put. They don't have to be one piece, because sometimes we have large wounds that because the sponges are only like 8 by 10, so they're not very big. Okay, so sometimes we'll have to pile them, in order to stuff it in the wound. Now, I know it's hard to cut it in this particular shape, right? It's hard. So what we do is, you can't see it, but there's a transparent dressing we put on the periphery of the wound. So what we do is we put a drape here, which is Tegaderm. Okay, so we have large Tegaderms, like 8 by 11 sheets, just like paper. Okay, we have Tegaderm here, Tegaderm, Tegaderm. And then we'll expose the wound. So we'll cut the Tegaderm using clean scissors. So we'll make an opening. So we'll expose the wound. So first we covered it all with Tegaderm. Yeah. And then we have to expose the wound. So we'll cut the Tegaderm, okay, to expose the wound. Only the wound, meaning this area here is the wound. The wound, the skin around the wound is called the periskin. No, peri around. So peri around, skin around the wound. So the periskin has Tegaderm, right? Because we only expose this part here. So once we expose the wound, then we'll stuff the foam there. Then once we stuff the foam, we put Tegaderm again on top of the foam. All right. So even if it's not the same shape, don't worry, because even if the foam goes over the periskin, you protected the periskin because you have Tegaderm there. Remember? Because you laid Tegaderm all over the place, right? So once we have Tegaderm over the foam, we'll cut a small hole and then put this disc over it. And then this is attached to a machine which will create the vacuum. So once we turn on the vacuum, it will suck all the air out of the wound bed. So all this foam will go like that. Of course, right? Because you created vacuum. So now you created an anaerobic environment. Now no air, no oxygen, can bacteria grow? What happens to all the drainage also? You're sucking them out also. So this therapy, look at this. This is the same wound. A few months later, look at that. It closed the wound already. Okay. So this wound would normally take maybe a year or a year and a half to heal. With this therapy, it will cut it down to maybe 3-4 months. Okay, as long as there's no infection. Okay, so this is nice therapy. If you go to home health, it's a nice side hustle. You handle therapies like this. Hey, it's fun. Yeah, it's fun. I enjoyed it.
So where do they usually put a wound?
We only put it in clean wounds, chronic wounds like this, but it has to be clean. If it's infected, we can't put a wound back in there. Because if you put a wound back on an infected wound, that means you're containing yeah, so we have to treat it first. Again, changing the dressing, we have first surgical dressing will be the surgeons. Don't worry, they make rounds early in the morning, okay, around 4, 5, 6, they start already. Before you know it, it's already finished. And then subsequent dressings, they'll give you instructions on what to do, so you follow them. So of course you do hand washing, right? And then aseptic technique. Maintaining normal body temperature, of course. Have you ever been in an OR wherein it's nice and warm?
School.
Who's ever had surgery here? Was it nice and warm in there? Did they give you a jacket, a sweater? No, your butt was on the stainless steel. Yeah, so on the ice cold stainless steel table, right?
So the bear hugger doesn't.
That's if the patient gets hypothermia, so we can use that. Warmers, but we maintain body temperature. So for both extremes, if patient has hyperthermia, then we ice them. If it's hypothermia, then we warm them. We already discussed PONV from the outpatient surgery, so it's the same here. Here's your wound care instructions. Okay. Until sutures are removed, clean them. There's really no need to do sterile technique. We just do medical asepsis. In fact, we encourage the patient to take a shower. Okay, so running water will clean the incision. Okay, just soap and water, and make sure you pat it dry with a clean gauze. Okay, and then keep it covered. And then what to report? Okay, what symptoms to report? Again, redness, swelling, tenderness, erythema, or drainage. In relation to post-op nausea vomiting, we also have problems with constipation. Voiding, there could be urinary retention. Okay. So what is your first action? There is, you suspect urinary retention. The patient hasn't voided. So what do you do first? You call the doctor right away?
No.
So what? Okay, so you have to assess first. Is the patient not voiding because they're not making urine? Or is it because they have urine, but it can't come out of the bladder? So you have to distinguish. So what is the problem? So how do you investigate? Check the bladder first. Okay, so check the bladder. Is the bladder distended? Okay, if there's bladders doesn't feel distended, or let's say the patient's obese, you're not sure, then go get a bladder scan. Okay, so assess first. Then you report your findings to the doctor, and then you and the provider discuss the best action forward. Okay, do we put a catheter or do we put a straight catheter? Okay, you agree. Or if it's because the patient's not making any urine, then check labs. Maybe patient's in AKI. Okay, maybe oliguric. Okay. All right, so we just finished for neurologic, I forgot. Patients can have a stroke after surgery. okay, because of blood clots from surgery. That's why we prevent DVTs. That's why we do ambulation, etc. But sometimes we miss it. Okay, patient has a clot and then travels to the brain, then patient gets a stroke. We'll do stroke in 2 weeks. For VTE, we discussed already prevention. Management of DVT, we'll discuss module 6. Infection again, we have 3 W's, we discussed that. All right, last 2 complications. What to do with wound dehiscence and evisceration? So what's the difference between the two? Dehiscence is when the incision opens. Okay, doesn't matter how open it is. Maybe just 1 centimeter or let's say 6 inches. Dehisced wound is a dehisced wound. Okay. What about evisceration? Okay, when you have abdominal organs coming out. So therefore, can evisceration happen in any other part of the body besides the abdomen? Can evisceration happen anywhere else in the body besides the abdomen? Where?
Wait, no.
Okay, so no, right? So when we say evisceration, that means this is a abdominal incision. What about dehiscence? Can it occur in any other part of the body? Yes, it can occur on a knee, an elbow, shoulder, back surgery, or even a skull incision, right? So what do we do? And here are the risk factors for dehiscence. This will precipitate, okay? So there, that could be select all of the flag question there. Let's go to management. So what do we do? What do we do with dehiscence and what do we do with evisceration? Well, prevention, we already discussed this with straining, with prevent during coughing, because here it tells you that, so what will cause dehiscence? So the risk factors are again the following. Okay, if the patient is coughing, for instance, or let's say the patient's obese and did not splint the incision properly, they moved, okay? Or here, patients on steroids, so those are all factors that will affect wound healing. Management now. So what do we do? Okay, so the patient may report this, that something gave way. So here's your management. In this particular order. So what if the question on the exam will be, okay, place your actions in chronological order. So what's the first action? Read it. The cover is in the last statement. So what is the first statement? Okay, positioning is your first action. So what position do we place the patient with evisceration? Low Fowler, which is how many degrees? 15 to 30. Okay, so 15. And then what do you do next?
Cover with sterile dressings.
Moisten with, okay, all right. And then call the surgeon in that particular order. Are we clear? Okay. And the rationale is here. So why do you put the patient in this recumbent position? Minimize further protrusion of organs, okay, or tissues. All right, that's it. Any questions?